Hello everyone. Welcome back to Avercode Medical Coding. In today's video, we'll be diving into the live coding session focused on inpatient DRG coding. We'll go through a real-life case scenario, using coding guidelines to accurately code the chart. Each code has unique documentation requirements, which directly impact billing and patient care. So, let's get into the details to ensure precise and compliant coding. Today, we're examining the chart of an 82-year-old female who was admitted due to breakthrough seizures. The patient's medical history includes seizures, COPD, paroxysmal atrial fibrillation, aneurysm with status post-repair, bipolar, anxiety, migraine, status post-right below knee amputation. As you are reading HMP of the patient underwent some assessments such as CT head, urine examination, and neurology was also consulted. Patient is on brivaracetam 100 mg and lamotrigine 200 mg medications. Patient is also taking Topamax for migraine, home inhalers for COPD, aspirin 81 mg for paroxysmal atrial fibrillation, trazodone for insomnia, and continued Latuda 30 mg medication for bipolar disorder, metformin for type 2 DM and amlodipine for hypertension. Since the patient is actively being treated for these conditions, they must be coded as secondary diagnoses. Next, move on to consultation report. In the first line of documentation, it is documented as focal epilepsy due to brain injury from SAH, that is subarachnoid hemorrhage. This indicates that the epilepsy results from a late effect of an SAH, caused by a brain injury. Remember this point, and we will discuss later about it while coding the chart. Pause the video and read the report carefully. Next, move on the progress notes. A new diagnosis of a urinary tract infection, UTI, was noted, for which the patient was prescribed ceftriaxone. Additionally, there's an update on the breakthrough seizures, documented as RN witnessed her episodes, see RN document on September 13, likely PNES. PNES stands for psychogenic non-epileptic seizures. Since the patient is actively being treated for these conditions, they must be coded as secondary diagnoses. Next, move on to the discharge summary. The discharge summary also has same documentation. Patient had breakthrough seizures, and also there is a documentation of likely PNES and requested for further neuro re-evaluation. Since the patient is actively being treated for these conditions, they must be coded as secondary diagnoses. Let's code this chart. Patient was admitted with breakthrough seizures and patient had epilepsy due to brain injury. When the patient has seizure and epilepsy, we need to code only epilepsy, but epilepsy was due to late effect of subarachnoid hemorrhage of brain injury, so we need to code epilepsy first followed by sequelae of subarachnoid hemorrhage, which is late effect condition. Let's see what coding guidelines says for late effect coding. The specific type of sequela is sequenced first, followed by the injury code. So code first epilepsy as principal diagnosis followed by sequelae of brain injury, then additional secondary diagnosis, which are documented in HMP, progress notes, and consultation reports. Pause the video and check all the codes carefully. Let's pause here to address the documentation of likely PNES in this chart. Since PNES is noted as a possible diagnosis without a confirming psychiatric evaluation, it's important to submit a coding query to clarify its clinical presence. Refer to the query template provided to guide this step. Pause the video and look at query template. Finally, DRG assignment for this chart. MS-DRG for this case is 101, seizures without MCC. APR-DRG for this case is 053, seizures. Use this case as a reference to better understand the approach to coding complex inpatient charts accurately. Thank you for watching, and be sure to subscribe to Avercode Medical Coding for more in-depth training sessions. Let's keep coding accurately and ensuring quality in patient care.